Dr. Flasher from Doylestown Hospital. We're so grateful that you were able to join us today and talk to us about prostate cancer and awareness of Prostate Cancer Month, which is September. So thank you for joining us.
Sure. Thank you very much for attending. And I'm Steve Flasher. I'm sort of a local guy. I grew up in Northeast Philadelphia, went to Northeast High School. Got my first car at Faulkner Buick. The dealership was about 10 cars, and I can't believe when I come here and it's a full town of Fred Beans people. So anyway, I'm really honored to be here. I make my living because of you people. So I appreciate it. If I can give back to you 1/1,000,000th of what you've given me over the years, I've done my job today. So thank you. And I was going to do a rectal exam up here, and they volunteered Mr. Beans, but he said he was running a little late. So Mr. Branchide, we're just giving you a little warning. Well, anyway, today, September is Prostate Cancer Awareness Month. And when I started residency at Duke University, the cure rate for prostate cancer was 20%. And it was because it didn't change the amount of people were having it, but we were discovering it later and later. We have less and less options. So the point of today's lecture will be to help educate as to what is prostate cancer, what is prostate cancer, and means to detect it, and also means to treat it if we have time. But please, everyone in the audience and at the other dealerships, if you're listening, if you want to text a question or if you have a question, please raise your hand and just try and make it germane to the whole group. But at the end of the time, after answering general questions, I'd be more than happy to have a private question and answer period for anyone who has an individual or family question. Okay, so let's get started. So prostate cancer. 1 in 9 men will get prostate cancer. It's the second leading cause of cancer death in the United States, and lung and GI are in the top 3. Okay, colon cancer. And the number is at 0.5% per year after the age of 50 men. After the age of 50, men will develop prostate cancer. So if you're 60 years old, 60 minus 50 is 10. 10 times a 0.5% chance per year, 5% chance. So if you're 60 years old, you have a 5% chance of prostate cancer. And that goes into the equation when you're evaluating what's my chance of cancer. If I have this test, this experience, these are my symptoms, are you different than Mr. Jones or Mr. Smith? So we'll get to that in just a second. As we get older, men's prostates grow. So as they grow, you have symptoms, and we've developed or break into symptomatology 2 types of symptoms. And that's obstructive symptoms and irritative symptoms. Unfortunately, you can have both with either benign enlargement or cancerous enlargement. And that's one of the reasons why the cure rate was 20% in 1986 to 1990 when I first started training, and why it's now 80%, because all we could rely on back in the day when I was a dinosaur was your finger exam and your symptoms. But the symptoms of enlargement and obstruction are very similar whether it's benign or cancer. So you can't just say, gee, I get up at night, I must have cancer. That's not correct. So the symptoms you might have from prostate trouble would be bladder outlet obstruction, boo. So think about it, it's obstruction. So slow stream, can't empty, walk away, come back 5 minutes later, getting up several times a night. Those are obstructive symptoms from enlargement. Not necessarily cancer, but it could be cancer. And then we have fun, F-U-N, frequency, I'm going all the time, urgency, I'm going urgently, and nocturia, getting up at night. But they're not specific. It's your body telling you that you're different than you were when you were younger, but not necessarily that you have cancer. So if someone says you must have cancer, you're getting up 6 times a night, maybe you have sleep apnea. But it doesn't necessarily mean you have cancer, but it is a warning sign to you guys that something's different than you were when you were younger. So what is the prostate? Well, it really has very little to no function when you're my age. It helped make and store the semen that kept the sperm alive. So sperm come from your testicle, they go to the prostate, they store there during ejaculation, you ejaculate out the sperm, and the white creamy stuff, the semen, is produced in the prostate and helps you keep the sperm alive so they can achieve a baby. It has no use at all when you're past your childbearing, child-fathering years. It's a sizable walnut, although certainly by your DNA, something you could blame your dad for, Some men have very large prostates. Some guys have smaller prostate. The average prostate is the size of a walnut, and that's detected by the rectal exam. So what's prostate cancer? So prostate cancer is you have benign, so as you get older, it just grows and grows and grows slowly every year. And it causes obstruction, it can cause irritation, but it's not cancerous. Cancerous is when a cell mutates and the cell itself becomes no different than breast or lung cancer. Some irritant, something causes the cancer growth to become awry, and it grows independently of what it's supposed to be. It triples in size, it causes irritation, it grows roots, irritates the men's urinary system, and you get frequency urgency nocturia. Once again, you can get that with benign growth, but this is now speeding up. So what are the signs of prostate cancer? So you go to the doctor, we put our finger in the rectum, and you feel the bottom of the prostate. You can't feel the top of the prostate. So if you just go to your family doctor, and not every family doctor, not every nurse practitioner, not every PA does a rectal exam, but you can only feel the bottom of the prostate. So you're feeling for nodules, you're feeling for asymmetry, hardness. It feels like a rock. You can just go, oh, that's a nodule. However, that is a late finding for most people. First of all, if this is the prostate, the top half has an equal chance as the bottom half of having cancer. So right off the bat, half the cancers on a rectal exam will be missed until it gets to the bottom of it. So once again, back in the dinosaurs, if you felt a prostate cancer, either start on the bottom, that was a 20% cure rate. You start on the top, you're shit out of luck, excuse my French. Because by the time it got to the bottom, by the time you had symptoms, frequency, urgency, nocturia, by the time you had frequency, urgency, nocturia, there was enough cancer to irritate the prostate. Clearly, this was not enough to fill out for cure. So the nodule was good, symptoms are good, but you guys and your wives' antennas should be up. Something had to come along that was better than a rectal exam and your symptoms. It found some, 20% early, 80% too late to cure. So, blood tests. So, my union, the AUA, says you should get one between 55 and 69. It's really been expanded to about 50 to 70. But I've done PSAs on younger men. I've done PSAs on 80-year-old men. To me, if a person asks for it, it's the right thing to do. You might argue with your family doctor. I can't help that. The insurance company might not like it, but it's my bailiwick, so of course I'm going to recommend a PSA. So what is PSA testing? So back in the day, we didn't have any blood tests for prostate cancer. Just like breast cancer had mammography to screen for it, but prostate cancer, the second leading cause of death in men, had 0. And men are notoriously, no one's really in this room volunteering to have a rectal exam. Okay? So, but a blood test, a little bit more palatable, and there was no such thing. But they found that prostate cancer or prostates in general made a protein. So it's specific to prostate. So PSA is prostate-specific antigen or protein. So if you have lung cancer, PSA doesn't have it. But PSA is a very, very sensitive test. It's a protein made by the prostate. So prostate cancer grows faster, PSA goes up faster, goes up. PSA causes rapid growth, PSA faster. So there's certain things about PSA testing. For instance, you might not know, is that you're not born with the same PSA that you have when you're 50, when you're 60, you're 70. So PSA when you're in puberty is 0, 1, half a point. But as we get older, your acorn-shaped or sized prostate becomes a walnut, your PSA goes up. So if you hear, oh, my PSA was 1 last year, it's 1.3 this year, expect it. Every man should expect it. It's going to go up linearly, slowly. There could be one weird one that goes from 1 to 3, and repeat it goes down to 2, but overall, it's a nice, gentle upward curve. So that's one thing. Also, PSA is proportionate to the size of your prostate. So if you have a massive prostate versus an average prostate, that man's PSA of 10 is equal to that man's PSA of 4. But start somewhere is with the blood test itself. So you can't go wrong getting the blood test. Okay? And that's what Prostate Cancer Screening Month of September was all about. When it first came out in around 1986, no one knew about it. Now it's common. Now it's ubiquitous. Now it's part of every single lab that a man will get once a year. Yeah, we show. So the PSA test is a sort of an inroad to find cancer earlier. So what happened was you have certainly a lot of advertising, prostate cancer. You have Norman Schwarzkopf, you have Stan Musial, you have a lot of famous people with prostate cancer. So that gets the word out. But really it's the blood test, the PSA, that sort of drove the train forward, that people now have a cure rate of 80% versus a cure rate of 20% one generation earlier. Okay? So the blood test. The digital rectal exam, I explained to you that no one likes that, but you can have a positive nodule and a normal PSA and still have prostate cancer. Some of the worst cancers don't make PSA. So I always tell a person, you can't rely just on the PSA. You'd like to, but it's really a part of the comprehensive exam of your primary care doctor to get both the PSA and a rectal exam. Okay? And let's just say you're at your family doctor's and the PSA is elevated, but you don't know if it's cancer. What are your options? So your options are that the main diagnostic endeavor is a biopsy. And it's rather simple. If a person's PSA is 20, with the normal being 4 for most age groups, you're not going to go wrong recommending a biopsy. There's a gray zone because the PSA could be, if you have a big prostate, and remember, you can only feel the bottom of it, so how do you know if it's a big prostate or not? You do an ultrasound. So there's different tests. A is the PSA, Z would be the biopsy, but it's very invasive. It can cause you to be admitted to a hospital. It can cause you to bleed or have infection, but it's the only test that will tell a man if he has prostate cancer. But before you get to that, you want to make sure as a urologist that you're not biopsying everybody. So for instance, theoretical, so it's a simple thing. The PSA was 1, it's now 10. You repeated it, it's 10. You better check a biopsy if it makes sense. If a person, though, is 68 years old and PSA should be 4, and his is 5, maybe it's the size of his gland. So that's where the expertise of urologist comes in. He might do an ultrasound. He may do what's called a good and bad PSA. So there's a test where you could, well, if you have a high cholesterol and the cholesterol is high, but it's all good cholesterol, who cares? Well, there's actually good and bad PSA. So you can fractionate an elevated PSA to see if you have prostate cancer or what your risk of prostate cancer. So going back to my first statement here is that you take a 60-year-old man, and it's a 0.5% chance per year of prostate cancer. He's 60, he has a 5% chance. So if in your own mind the dialogue is, gee, his PSA is 7, it should be 4, he's got a 20% chance of prostate cancer. You discuss it with the patient, you say, listen, sir, your PSA is 100, you got prostate cancer. But that gray zone, which most people have, is it went up too fast, or it's too high. You have the dialogue with the patient saying, gee, you have a 20% chance of cancer, but your age group should be 5%. I'd recommend a biopsy, or let's watch this. Okay. So biopsy is the standard of care when you have a higher degree of suspicion. If every time I did a biopsy was positive, I didn't do enough biopsies. If on the other hand, I do so many biopsies that I'm at the same rate as what they should be, I did too many biopsies. So you're a consumer, just ask the question, do you think I need a biopsy, or is there anything else we could do, such as a good and bad PSA? Should I get another test, such as an MRI? Should I get an ultrasound? But at the end of the day, you have to rely a bit on the expertise of the urologist, your family doctor, and your own intuition. You guys didn't get to this position by just flipping a coin. Does it make sense what the doctor is saying to you? But those are the options we have to evaluate prostate cancer. Before I go on, if there's any questions about that up to this point? I got you all snowed or bored, or you're not eating a chicken salad or something? Okay, so you do a prostate cancer biopsy, and it comes back positive for cancer. So every patient will ask you, well, doc, how bad is it? I'm sorry, let me go back one second, because it wasn't on the screen here. what about prevention? Okay, so what about prevention? I just talked about early deciding it, early diagnosis, but can you prevent it? Well, if you're castrated before puberty, you won't get prostate cancer. Not the greatest idea. Okay, now there's been a bunch of medicines touted for prostate cancer. So, and also some vitamins. So the one that's the most commonly discussed is saw palmetto. So you might see in the drugstores, Men's Health brand, Prostate Health brand, saw palmetto. So generally speaking, all those are designed to take your money and not prevent anything. Now saw palmetto does have, it's an herb found in Georgia, and the Indians who eat saw palmetto in their regular diet have a low degree of prostate cancer. Does that mean it prevents it? It could. Japanese men born in Japan have a very low chance of prostate cancer. Japanese men born in Japan who come to America have the American rate of prostate cancer. So clearly something in our diet causes prostate cancer, where it exacerbates the gene that you may have inherited from dad or from your uncle. Not your uncle, dad or grandfather or brother. So if you have an uncle, it doesn't count. Grandfather, father, brother, you have a higher risk of prostate cancer. You should be tested. But could you prevent it? If your dad had prostate cancer, can you prevent it? There's no data whatsoever that saw palmetto prevents prostate cancer. But it does have some weak properties to keep the prostate from growing quickly, so it's a possibility. It's safe, it's innocuous, but as a physician, I can't give you non-scientific data, but I can tell you that the zinc compounds, the zinc things, prostates have a lot of zinc in them, so they sell zinc compounds. You have more zinc in your diet than you can do with. You don't need more zinc from a pill. So if you're going to buy something, you buy CVS brand saw palmetto, Fred Bean saw palmetto. So, but you don't need to get Men's Health formula. It's more expensive than you need. Now, leukotrienes, which are sold in pills and tomatoes, they are antioxidants. And the general thinking in medicine is that antioxidants prevent prostate cancer. So you can have a pill that has leukotrienes. You can have a diet rich in tomatoes. So if your father or brother or grandfather had prostate cancer, it wouldn't hurt you. It's something you could do. The medicines that were touted was vitamin E and also a drug called selenium. And they absolutely prevented prostate cancer to a degree. Having said that, when they did it over 10 years, selenium patients got diabetes higher than the regular population, and vitamin E had higher chance for bleeding than the regular population, had cerebral hemorrhage. So it does work, but no one's touting selenium and vitamin E. Last drug is actually a prescription drug, Finasteride. And Finasteride is also sold as a 1 milligram for people with hair loss called Propecia. And that actually does work to prevent prostate cancer. Now, there's a double-edged sword with that because since they've been taking Finasteride for many, many years, it came out in like 1986, the people who took it, much less percentage of patients did not get prostate cancer. So if the average population is 1 in 10 over the course of time, and you took Finasteride, 1 in 30 Finasteride patients got prostate cancer. Well, we put a score on this, and that's what's going to lead up to my next slide, is how bad is the cancer? They all got worse cancer. So if the average is, if they put a number on prostate cancer, how bad it is, 2, 3, 4, nothing, 5, 6, 7, medium growing, 8, 9, 10, killer, widowmaker. The people on Finasteride got 8, 9s, and 10s. And to this day, no one knows is that it prevented the 2, 3, 4, 5, 6, 7, so that the people who got it got a higher number, or the Finasteride caused you to have a worse cancer. But I put patients on it with my disclaimer, but it's hard to be a salesperson or a urologist and say, hey, sir, I think you should take Finasteride. Your father had prostate cancer, your brother had prostate cancer, but if you get it, you might get a 10. You know what I mean? So that's the dialogue. But so those are things for prevention. So it really comes down to, unless you castrate yourself as a teenager, you're going to have early finding, okay, early detection. So every patient who has prostate cancer says to me, Doc, how bad is it, and what should I do about it? And that comes down to Gleason Score and staging. Now, a couple things. When a PSA is under 10, and the person has the average prostate cancer, which is 5, 6, or 7, the chance of a spread is 1 in 1,000. So it's early detection under 10. I mean, average patient. If it's 8, 9, and 10, can't always go, but the average patient, a PSA under 10 is completely curable if found early. Okay. After 10, the chance of spread to the bones, lymph nodes goes up every point over 10. Now, there's a thing called a Gleason score. Now, Gleason was you can almost imagine a mad scientist in the basement of his pathology lab, and here's Mr. Jones. Oh my God, I did a biopsy on him 6 months ago. He's dead of prostate cancer. Here's Mr. Smith. He died of a heart attack, and I diagnosed him 20 years ago with prostate cancer. So they knew there was fast growing, slow growing, medium growing, and that was Gleason. And Gleason made a score depending the way it looked under the slides as to is this fast growing, slow growing, or medium growing. And he predicted, and he made a prediction. I could look at the slide and say, this is what you have, and how long you have. So when you get prostate cancer, let's say you're at Gleason score 6, you weren't a 4 last year, you weren't a 3 last year, it wasn't 3 last year, 4 this year, 6 this year, next year will be a 10. What turns on is the same number, 6, 7, 8, 9, 10. But what changes is the stage. The stage is more and more and more. The longer it takes to diagnose it, once you get early detection, the harder it is to treat because the stage becomes 1, 2, 3, 4. I don't want to confuse you between the Gleason score. Stage 1 means you can't see, you can't feel it. You did a test and it came back cancer. Stage 2, guys, PSA was elevated. Doctor couldn't feel that nodule. Ultrasound couldn't see a nodule. You did a biopsy, it came back positive. That's stage 2. Stage 3 is, oh my God, there's a nodule there. Stage 4 is like, oh my God, don't even do it. That's got the PSA of 100. It's been there for so long. So what happens is you get more and more and more cancer, but it's still the 6, 7, 8, 9, or whatever it is. It's the volume that changes. So based on the volume, is it T2, T3, T4, or is it a Gleason score of 5, 6, 7, 8, 9, or 10? That can tell Mr. Jones, gee, what Gleason said about your score was, and you fill in the blank. So for instance, the person, here it is, the average patient in your practice comes in, his PSA was 7, I thought he needed a biopsy, ultrasound didn't show very much, rectal exam didn't show very much. He didn't feel like, Doc, nobody in my family has prostate cancer. I probably don't have it. Well, your PSA was 3 last year, it's 7 this year. Prostates don't double in size from 3 to 7 in 1 year. Let's find out if you have it. There's always a first in your family. And sure enough, that man will have prostate cancer. Not sure enough, but he has prostate cancer. So you sit down with the patient, listen, your PSA was under 10, chance of it spreading was next to 1 in 1,000, and you have one small gland of prostate cancer, one small area. What should I do about it? Well, your stage is T2, your Gleason score is 6, 7, 5, 5, 6, or 7. You have, according to Gleason, here's the nice part, is that prostate cancer comes slow growing, for the most part, medium growing. You have lung cancer, 6 months, pancreas cancer, 6 months, unless you're extraordinarily lucky, you have limited time on Earth. Prostate cancer, an average score of 6 or 7 is, Gleason would say, is 9 years to spread and 5 to get you if you did nothing. So Mr. Jones, you're 72 years old. I'm not even sure why I biopsied you, but I did. According to this, you're going to make 10 years if I don't do anything. You might want to watch this. Mr. Smith, you're 61 years old. I don't mind watching for a little while, but you got 9 years to spread, 10 years to 12 years to get you. You want to make 80, don't you? Well, I'm afraid of the treatment, which we'll get to. Well, yes, but you should be afraid of death. So we're going to do something. By the way, real quick for you. So Jerry Seinfeld, okay? He says, he was up on stage, he goes, you know, I read this report that if you give a lecture, if they ask them, what are people afraid of? So, and if you're afraid of something, you're afraid of death was number 2, but public speaking was number 1. He goes, that means if you're giving a eulogy, you'd rather be there than up here. Well, I'd rather be down there than up here, but I'm doing my best. So, anyway, so
Great.
There you go. Thank you. I didn't know my brother was here. Okay, so the Gleason score and staging tells us how to tell the patient what his prognosis is. Okay. And so age and health. So does everybody need treatment? Well, I hate to say it, but they're older, people have strokes, heart attacks, no one's going to live forever. I try not to biopsy someone if I don't think in my own mind, and I might not say it out loud, but my thought bubble is, what the hell are they here for? This guy is 78 years old, and he's got diabetes, stroke, heart attack, and he had lung cancer. Believe me, I get patients like that because there's that box. You get your labs, and it says PSA 4 at 4.1, and 4 is normal. It checks a box, and they'll come over because it says age high. So I try to match the patient's health with what if this was average prostate cancer. So I don't even do a biopsy if I don't think the person would benefit. I had a 78-year-old patient yesterday. PSA was 4, 8, 14, 19 in 1 year. He has a nodule. He's 78 and healthy. He's getting a biopsy. But so it's not just by age, it's by the whole picture. It's your health, it's your age, your score. And once again, I want to remind all the men and the women in the audience that your PSA goes up gradually. So as your prostate grows. So 4.0 is the number benchmark that everyone knows. But if you're 50, your number may be 2, less than 4. And if you're 70, it might be 6.7, 7. So once again, the only person who's going to follow this as well as you guys is you guys. I don't come to your house, but if you say, well, if you say to the doctor, what was my score? He goes, oh, it was normal. What was my PSA? It was normal. Well, what was it? Okay, it was 2. Okay, and next year it's 3.9. It doubled. So it's going to say normal. So no one's being more proactive than you are for your own health. Write it down. Ask them, what was it last year? You have your annual physical. Find out what it is, because 2 to 3.9 will not show up, but 3.9 to 4.1, which is benign, will show up as high. Right? So trust your family doctor, but trust yourself to at least inquire what was last year. Keep a little thing in your smartphone. Keep a last year, this year, especially if you have a father, brother, grandfather with prostate cancer. So it's not just the number, it's the rate of change. And it could be wrong, but that's my job. Should I repeat the test? Should I do a test? You don't have to have a biopsy necessarily, but that's how you find the early cancer. It might not be 4.1. It might have gone from 1 to 3.5, and prostates don't grow 3.5 times the size of normal in 1 year. If you want to have a black pearl, that's one that may not be exactly correct, 1 point per year. So 3 to 4 percentage is better, doubling or something. But if your PSA went up more than 1 point, it's a little, some thought bubble. Maybe I should repeat this test or see a urologist like that. Okay, so you're diagnosed prostate cancer. What do you do about this? So what we're trying to do is in broad brush strokes, okay? Because there's no one treatment for a 70-year-old guy, a 50-year-old guy. There's no one treatment for a person with impotence versus incontinence and stuff like that. But 3 categories: watch it, operate on it, or radiate. Okay? So the surveillance, active surveillance, is, we used to call this observation. But observation usually means I'm observing it. By the time you're observing it, you get frequency and urgency and nocturia, fun. It's going to be the 80% cure rate's gone, and you now have 20% cure rate. So you can't really watch it until you decide, I'm done, I'm done watching. So why would anybody watch prostate cancer? Well, you'd watch it for one, if you're so old, it's not going to, you don't need to be treated. If you think you're older and you're 78, you don't want to have treatment, the treatment may be worse than the disease. You heard you die with your disease rather than from your disease, they're all true. So if you're having symptoms, you might treat it, but you might just watch this and see what happens. But what about the 50-year-old guy? Why is he watching it? Well, treatment for prostate cancer is extremely changing the quality of your life. Surgery has a high risk, up to 100%, causing impotence. So you take out the prostate, and up to 100% of the patients of surgery will be impotent. No less than 33 to 50% So not all broad brushstrokes, 50 to 100% of guys will not have erections like they had before the operation. Radiation, it can burn your rectum, it can burn your bladder, and even if everything goes well, it still can cause impotence because it burns the blood vessels. So you're not as dramatic. You wake up from surgery impotent, and hopefully it comes back. But if you irradiate a person 2, 3, 4 years later, you're losing your erections because you burned them. So why would anybody want to treat that? Well, if the disease is a 10-year disease and you have 20 years of life, I suggest dying is a worse option than impotence and incontinence. But suppose you could kick the can down the road, so you delay treatment. That's where the 50-year-old guy does active surveillance. So you talk to your urologist, you talk to the radiation therapist, you talk to whoever, and you try and make a plan that makes sense for your family. Is I'm going to watch this. Every year I'm going to get a PSA, every year I'm going to get a biopsy. The only problem is that you can watch it too long. There's no metric that says, gee, today's the day you need surgery, or today's the day you need radiation, and there's no metric that says which of the two. So you're flying by the seat of your pants, just like your brakes. Should you change your brakes? Well, we have a little time. If you wait too long, you're gonna be on. I should use a different analogy for this group. Okay, so I'm out of my element here. But you can watch it too long. But what you're trying to do with active surveillance is kick the can down the road. You're going to get treated, but you're going to get treated next year, the year after, so that you have a quality of life. Okay, we're going to move on. So surgery versus radiation. Now, this is something that may floor on you. So why? Well, first of all, why does surgery not cure everybody? Well, so I told you that if the PSA is under 10, it has not spread outside the body. That's correct. Or to the lungs, the liver, metastatic. And the average guy is nowadays under 10. But locally, the roots, if you will, can go past where the knife of the surgeon can cut. So you take it out. Doc, how could you not cure me? My PSA was 8. You said the chance of curing me, spread was 1 in 1,000. I still have cancer in my body. Yes, sir. Well, what happened was, if you remember, your rectal exam was right by the prostate. Well, if that root goes down 2 eyelashes on your rectum, I cut across here, take out your prostate, the roots were still there. I didn't want to cut open your colon and give you a colostomy and not cure you. So if the roots are too far left, too far right, the nerves to your legs are too far left, too far right, so you won't drive a car. You won't be able to pull your legs in to drive if you cut the nerve trying to get the cancer out. So the answer is not everybody's cured from surgery because the roots are too far gone. And that happens, average guy, if there is, this is one where it's hard to say the average guy, let's say the cure rate's 75% or 70%. That's all comers. Hard to say there's an average, John Doe, but let's say 70%. Radiation, same thing. You didn't push the button. Why didn't you cure me? Well, about 30% of the time, the cells in your prostate cancer will not absorb the radiation. So you're going to fail. There's no test beforehand that says if you're radio sensitive. So he pushed the button right, he radiated the gland, but it came back. You had less complications, surgery, impotence, incontinence, pain, radiation, no impotence, no incontinence for a while, then you get problems with impotence later on. But the cure rates are the same for the average patient, 70%, 70%. Once again, I'm not trying to befuddle you with a number, but they're simple, 70%. Yes, if your PSA is 30, that number's not right. But average guy, that's why we're talking about early detection. Every year, your PSA goes up, less chance for cure, because the year later, the year after that, that you put off, the roots are farther away, farther down, farther back, or there's more cells, more chance for radio resistance. So cure rates, the whole idea is if the roots are too far, there's too many cells, you won't be cured. That's why the PSA was so important, because back in the day, when you did a rectal exam, by the time you felt it, 80% of the time, all that had happened. You couldn't cure them. So nowadays, the PSA is a very valuable tool, at least to get early detection. So anyway, the cure rates are the same for surgery versus radiation. Yet, why would anybody in their right mind choose surgery if the cure rate's the same as radiation? Also, my union, the AUA, says if you're 65 years and younger, you should choose surgery. If you're 70 and older, choose radiation. And if you're 65 to 70, mind you, all good health people, no one's going to operate on a 50-year-old guy who has stroke and heart attacks, doesn't need the biopsy. 65 to 70, flip a coin, which one? So national organizations, National Comprehensive Cancer Network, AUA, says 65 years and younger, surgery, 70 years older, radiation. Why? Because the cure rate is the same. So, punchline, if you do radiation, it doesn't work. So it's 70 guys, 62 years of age, have radiation, making this number up. 70% will be cured, 30% will not be cured. Okay, how about we re-radiate? Doc, it came back. How about re-radiating? Well, Mr. Jones, if it didn't work the first time, it's because you had radio resistance. It ain't working the second time. Oh, shit. Okay, how about surgery? Well, if you didn't want it when you were 62, you don't want it now when you're 70. But when this was done, the cure rate was basically 1% higher because the entire time that we were watching the PSA start to go back up, because we killed something, we just didn't kill all of it, the roots were growing. So we did that experiment. We went back and we took prostates out that were radiated, cure rates were nothing. 1% higher. So there's things like this and things like that, cryosurgery, things like that, but nothing really demonstrable. Surgery was the opposite. Surgery was, you took it out and you didn't cure it. You knew if you didn't cure it because the PSA would go up, and you can do radiation because you had not irradiated it. So 6 months later, 1 year later, 5 years later, it comes back. You cut across the root, not even knowing it, or if you did know it, you can irradiate it, and that cure rate's 50%. So if you have 70% with surgery, those 30 guys otherwise would die. Flat out die if you had radiation. You have another bullet in the chamber, another arrow in the quiver. All your eggs were not in one basket. I did all my analogies. So you can do radiation. So if the surgery didn't work, you can radiate the guy, and 50% of those 30 will be cured. So it's an extra arrow in the quiver.
What do you mean by roots? Like cells don't have roots. What do you mean that the roots?
Yes.
grow?
So cancer of the prostate has. Let's say you have a mass. See the word mass, nodule. You think of it as just one round circle, but they all have tentacles.
Oh, okay.
So they all have. They eat. So they eat with. They send out finger-like projections in every direction. So if the finger-like projection is too far to the left, too far to the right, okay. So you think about a breast nodule, do a mammogram, you can do a lumpectomy. You can't do that in prostate cancer. You have to take out the whole gland. Just like a mastectomy, you have to take out the whole breast if it's not just a discrete nodule, because there's finger-like projections. Okay. By the way, Gleason also had a fascinating finding, was that if you had 7 years or 9 years to spread and 3 more years to get you did something. You gained a year of your life. So if you had surgery, it didn't work. Instead of 9 years to spread and 12 to get you, 10 years to spread, 13 to get you. Oh, you had radiation. 11 years to spread, 15 to get you. Oh, how about chemotherapy? So we could take that 10 or 12-year disease and make it into a 15 or 20 by doing, by adding treatment. If you think about it, this is not exactly, this is an artistic license. If you think about it, this is your prostate cancer size of a thumbnail. You take it out, but you don't get the roots. You've taken out 1 year growth. So it has to go back, so you get an extra year. Then you're radiated, you killed 99% of it, but not all of it. So you killed another year. So you're bombing into Stone Age each time, giving you 1 extra year. So it's not without merit. Oh my God, I'm impotent, I'm wet on myself, I'm not cured. Well, you got an extra 2 years of your life out of that, and we can fix impotence, we can fix incontinence. You can't fix death. So I'm just telling you that might not be the idea that you come to my office with, but that's what I'm selling when you're in my office, that we're going to do something to try and cure you if it makes sense. So basically, the message I wanted to get across today was, you're in command of your own health. Don't rely just on your symptoms. You have a powerful test and a tool and a friend and family doctors with a PSA testing, but you need a rectal exam with it. and then go, and you don't exactly need a biopsy, but be knowledgeable in what you're doing, especially if you had a family doctor, if you had a family member with prostate cancer, because your risk is higher, but your risk every year is 0.5% for you. Thank you for listening.
Thank you.
Any questions?
Please.
Diet.
Yes. So.
I heard the tomatoes. Anything else?
Yeah, well, a diet actually would be a fish diet. So the Japanese men in Japan have a much higher fish diet. Men in America have a higher red meat diet. So that has been proven that a higher fish diet is beneficial with the prevention of prostate cancer. How good so? Can't tell you 100%. Do as I say, not as I do. My grandfather died of prostate cancer. I had a burger last night. But that's the way it got to die of something. But I got a PSA this week. I really did. And my business partner does a rectal exam every Friday. No, I'm like, we're not done. So, but anyway, but thank you. Any other questions? So, yes, Kelly.
So you can get a PSA on your insurance every year. It's not like a mammogram that's every like 5 or whatever,
Yes.
right?
So there's a screen, you can get, the question, very good question, $75 test. If you have a history of prostate cancer, if you have a family history, you can get it up to twice a year. If you have symptoms, you can also get it up to twice a year. But if you're just screening, I'm just here, it should be really, really 1 year apart. And I've heard some horror stories of patients who, gee doc, I had it January the 1st, and then I had it December 31st, because the office was closed January 1st, they didn't pay for it. But generally, it's a year and a day, because the insurance company's computer, well gee, a year was a Saturday, I was at the doctor's exactly 1 year. Okay. Also, PSA goes up with sexual intercourse, not 10 points, but it can go up a point. It can go up a point if you're doing crunches, a rectal exam. That's important because if you're the family doctor, he does a rectal exam and you get a blood drawn, you can drive the PSA up. It's usually not a lot, though. It's not like 2 to 10. It might be 2, 2.5.
My doctor tells me, my dad had prostate cancer, so I get the PSA as part of my test every year. And the 1 year he did want to do the rectal, I don't know why. Maybe he thought I was cute, but he
Oh, that was you. I didn't recognize you. You spun around. I would have said, oh, how are you doing here, Bill?
he told me don't go get your blood work for a month because
That's
him playing around there's
It's usually about 48 hours. So
he told me
crunches, but up there. You can walk, you can swim, but you're not bouncing up and down on a bicycle, and you're not doing sex, and you're not having a rectal stuff. But it's not short. It's short lived. Any other questions? Yeah.
Yeah. So you've seen a lot of research and how everything's changed. Did you see any better options than just radiation and taking?
So the question was, being that I've seen things now change, is there things that are better? And the answer is a million things. So let's just start with a couple of things. The surgery used to cut you open, wide open, take everything out. We're now down to almost outpatient surgery with a robot. The robot preserves continence better than cutting you open. So the pain, the suffering, the back to work, much better with the type of surgery being robotic. I mean, there are people who can't have a robotic if they had previous surgery, but the average person. We've gone from radiation that it was a scorched earth policy. Scorched earth policy, everything got burned. Everything. Horrible. But we've now put GPS seeds in the prostate, the machine that hovers over your body so that if you're breathing, they don't have to worry about that because the machine works with your gold seeds and they can irradiate a very, very tight window of prostate. It used to be 42, so you have less complications of colitis, bladder inflammation, prostatitis, diarrhea, much less. So the technology, we've gone from that to, I won't say proton beam because not everybody can get a proton beam, but in Doylestown Hospital, Fox Chase, they have these GPS systems. We used to do a 42-day treatment. Oh my God, 5 days a week, 8.5 weeks of treatment. We're now, you may have heard of CyberKnife. So CyberKnife is a company that makes CyberKnife, but it's not cyber, it's not a knife, it's radiation. But the point was, and I don't know the exact number, but let's just say you need 1,000 shot, 1,000 rads of treatment. So you used to do 1,000 rads of treatment over 42 days, 2 rads per day. CyberKnife condensed it to like 10 rads or 20 rads or 100 rads at one sitting. So instead of 42 days, it's between 5 and 17 back to your life. You get a big jolt, but it's faster. Back to you. We used to have, so my grandfather died of prostate cancer. Mrs. Rosen, Mr. Flasher, your father, this time, he has metastatic prostate cancer. We're going to take his testicles off tomorrow. So prostate cancer eats testosterone. So the not cure, but the place you in remission, cut your testicles off. So in 1938 or so, I think it was 38, they won the Nobel Prize. The family, doesn't matter. They won the Nobel Prize in medicine. First time they found that doing something could not cure cancer, but put in remission was a castration. So we went from that to around 1985. We learned medicine. You give a shot in the butt that tells the body stop making testosterone. So now you have a chemical castration, not a physical castration. So then the next step was a pill rather than a shot. So that came out. Now we have, but people who had castration still based on testosterone. Now they have a thing called novel hormones. And the point of this all is they're trying to get more targeted. So the fancy, sexy word is targeted therapy. So we've progressed from castration, medicine for castration, pills for castration. Now we have targeted therapy, all meant to keep you away from the ugly word chemotherapy. And every one of those steps shows a lengthening of your prognosis for death. So delayed survival, overall survival. So instead of 10 years, it's now out 13 or 14 years with these newer medicines. Some are infusions. They have a vaccine. Hasn't really worked that well, but that's the way people are thinking. Castration does something, but starves the cancer. But cancer, the prostate is pretty smart. It learns to eat other things. So Provenge is a vaccine. There's a prostate, if it goes to your bones, there's medicines to help the bones have less pain. And boy, that's also the thing, is the unfortunate thing is that with surveillance or failure, it's not Hollywood. I hate to say it this way, but if it's not Hollywood, it's not very pleasant when you have prostate cancer in late stages. What makes you you, what makes you your person, now have pain every day. Anybody's ever had pain, you don't feel very good. And you can't pee well, and you can't be passing blood. So all these things are meant to give you a better quality of life before you need something like chemotherapy. So we're getting overall survival, not cure. That's the goal center. That has not been yet done. But we're putting up these roadblocks, lengthening the overall survival.
Dr. Flashner, thank you.
Oh, thank you. And I really, guys, honestly, I appreciate so much you guys. Mr. Beans himself always took care of my practice, every one of you. I'm a car owner at Fred Beans, and my practice is filled with you guys.
What do you drive?
I have an aging fleet. I'll come down.
No, he's not on the sales side, don't worry.
Yeah, right. Thank you so much.
Thank you.
Really
If you have any
appreciate it.
questions, please, I'll hang out for a few minutes if you have a personal question.